Yeah, a very good morning to one and all again. So it's, I think, lovely to see so many participants joining for this seed cycling presentation. And I bring greetings from Belagavi. It is actually it is there in the North Karnataka. It is one of the state in the North Karnataka, and it's a beautiful city. You all are welcome here anytime. And today the topic assigned to me is seed cycling. Seed cycling is something related with respect to the PCOS. Now you might be hearing these terms very frequently: PCO, PCOS, and PCOD. I was made to understand that we have shared the link with the general public also. So I will be talking little in very simple way so that everybody can understand this concept of PCOS and of the PCOS with respect to seed cycling. Now, PCOS is the most common endocrine and the metabolic disorder in women of reproductive age. Okay, now we call it as polycystic ovaries, when this disease, or you can say when it is only retained to the ovaries, when the problem is only with the ovaries. When this problem aggravates or it goes for a longer duration, then it involves other systems of the body also, and then it is called as polycystic ovarian syndrome or the disease. And what usually you can see with PCOD patient is they are having obesity, their insulin levels are high, their androgen levels are high. You can see the symptoms of insulin resistance, their blood sugar levels are high. And it is the commonest cause of anovulation and the leading cause of the infertility nowadays. Can we go to the next slide, please? Yeah. Now, coming to the prevalence of PCOS, I can say that it is a silent epidemic which is affecting lots and lots of women. I have picked two particular studies from the India only. One is published by Indian Journal of Medical Research. You can see here it was published in 2019, and the prevalence was ranging from 3.7 to very high prevalence of 22.5%. So there was a difference of so much of prevalence rate, because the studies which were done, they have used different diagnostic criteria, and India being the diverse country, so diverse population has given this range. There was another study which has done the systematic review and meta-analysis of all different studies all over India, and they have found the pooled prevalence of 11.33%, which is also very high. Now, what WHO has to say, can you move, Shweta? What WHO has to say that PCOS is having an estimated prevalence, it's of 8 to 13%, which is very high in the reproductive aged women. And you can see in this figure that PCOS is affecting 1 among 10 women, which is eye-opener to all of us. And they say that initially it was like 50%, but now the recent one guidelines, if you check, they're telling that 70% of the women who have PCOD had not got it properly diagnosed. So you see the umbrella or the burden of underdiagnosis of PCOS. With underdiagnosis PCOS, we're telling that it is ranging between 11 to 22%. So imagine if it is diagnosed properly, where the prevalence is going to be. And previous slide, please. Yeah. So previous slide. Yeah. So more than 50% of the women with PCOS have high chances, more than 50% of the chances of getting even diabetes. And interesting, one more figure which I've got, which is not from WHO, but this is an interesting thing which I have got, which I've put here, is that the woman with the PCOS having 2 to 3-fold increased risk of even endometrial cancer. So it is very, very alarming statistics, to know. Next slide, please. So these are the symptoms and signs of the PCOS. A PCOS woman will be complaining of irregular menstruation. When we say irregular menstruation, she can be having scanty menstruation. She can be having, you can say irregular cycles. She can be having repeated cycles in a month. So it is having different presentation. If you'll do USG, we can see the ovarian cyst present. Excessive body hair growth will be there, which is called as hirsutism. obesity is one of the classical feature. The female will be find it difficult to lose the weight. It is also associated with severe acne at every age, which is representation of the adult acne, oily skin, and male pattern of baldness or thinning hair on the scalp. The female usually say that they're losing the hairs on the scalp and they're getting the hairs everywhere else. Many females come to us with the complaint of infertility. Then there is also presence of skin tags and the darky patches you can see over the neck, the black colored line, which are called as acanthosis nigrensis. So these are the some sign and symptoms which will make you aware of that you might be having PCOS. Yeah. Now, what are the causes of this PCOS? It's having many causes. You can see here, we will start with the genetic cause. So genetic, it plays 20% of role like in any other diseases, but usually I say to all the women, it's like a gun in your hand. Genetic cause is like a gun in your hand, but genetics will not decide whether you are going to get the disease or no. It is how you are going to take care of your genes, whether they are expressed or no with our poor lifestyle choices. So we are going to click this gun and express the disease if we have poor lifestyle choices. So yes, genetics is there, but again, it is again related to our poor lifestyle choices, which leads to this PCOS. Then there is chronic stress. You can say chronic stress leading to chronic low grade inflammation for years together, which usually leads to hormonal imbalance further and can turn into PCOS in the woman. Then coming to the insulin resistance is something like, when you eat food, your pancreas secrete a hormone which is called as insulin. And the work of the insulin is to take that blood glucose to various cells so that cell can do their cellular metabolism and can do their work properly. But what will happen here, because the visceral fat is more, and it is like a barricades, how you can see the barricades on the road and they will tell you take diversion, you cannot come through this road. So it's like a barricades which are present between your uterus and your brain, because brain and uterus has to coordinate to secrete hormones every month. So insulin is now not getting the signals properly, so it is diverting its routes and not able to take the blood glucose to the desired organs. So what will happen now? Insulin remains in the blood and you can see hyperinsulinemia. And resistance means there is resistance. And who is resistance here? The fat. Abdominal fat is the resistance which is not allowing the the female body to do its normal function. And the main important thing over here, which I want to highlight over here is, because many females complain of that we feel hungry very often. Now, this insulin was supposed to give the glucose to the cell so they can work properly. Now, they're not able to work properly. So what will happen here is, in spite of eating well, the signals are not going to the brain properly. And then women will say that we are feeling hungry because that satiety has not got its, signals. So that's why we say that obese women still feeling more hungry. It is because of the insulin resistance. Next, coming to the lifestyle, as I've already mentioned, that lifestyle is having the poor dietary choices, more of sedentary lifestyle, physical inactivity is leading to a lot of hormonal issues in the female body, finally leading to the PCOS and creating a hormonal imbalance. This is what we can see in our classical books. But what I have to add today in my presentation here is, when we take a lot of history of the patients, we usually try to even intervene into their kitchens. And we see that there is a lot of use of chemical pollutants in the kitchen. Everyone knows plastic is harmful for the health. Everyone know now aluminium foil is harmful for the health. Aluminium vessels are harmful for the health. Room fresheners, talcum powders, agarbatti, these all are harmful for the health. Somewhere we can see there are few studies, few scientific evidences are available which are showing that if we having these chemical pollutant in our kitchen, somehow they are related to our hormonal imbalance. So we have to take this also into consideration when we are talking about PCOS. Next, coming to, can you please move ahead, Shweta? So with this, how we are going to diagnose the PCOS? What is the diagnostic criteria for PCOS? The classical criteria, the gold standard for the diagnosing PCOS is Rotterdam's criteria. So Rotterdam criteria says that the female should have either high androgen levels or menstrual irregularities, or they should have polycystic ovaries when they are doing ultrasonography. Now we will take one by one and understand. This Rotterdam criteria say if a female is having two out of these three, we usually call them as to have a PCOS. Now coming to the first thing, that is more androgen levels. We check more androgen levels with the clinical and the biochemical tests. So clinical test here means what we do is we'll do the clinical examination. We take a lot of history, and what we see here, this is called as Perryman's-Galway score, and we will see whether they're having the hirsutism. It means presence of hair in these different parts of the body, like on the chin, on the upper lips, on the side of the chin, on the near the abdomen, near the chest, near the vaginal region, increased hair actually, and near the back. So if the score comes more than 8, we usually call that female is having hirsutism, which is a classical feature of PCOS. Then we go to the biological findings. Can we go to the next slide and then come back in the first slide? Yeah. In biochemical testing, we have this many testing. Usually the classical book says that we have to test for the androgens, like serum testosterone level. You will see it is high in the PCS woman. Then there is one protein which is called as sex hormone binding globulin, which comes high. And then we have DHA level and androstenedione. So these levels comes usually high, but in our practice, what we do is we will do extensive biochemical, we advise extensive biochemical testing because of the various reasons. We also see here, reasons I will explain in a while. We also see insulin resistance. We usually check their fasting blood glucose, fasting insulin, oral glucose tolerance test, HbA1c, and insulin resistance by HOMA insulin resistance index. We also check their fertility profile, that is follicle stimulating hormone, luteinizing hormone, FH to LH ratio. If it is more than 2, we usually call it as, female is having PCOS. Serum estrogen level, anti-Mullerian hormone level, they are also increased in the PCOS, and serum progesterone. Serum progesterone just to see that whether they are ovulating properly or no. And these all symptoms have the very similar features in other diseases also, like thyroid diseases. So we want to do the differential diagnosis before we treat the woman for the PCOS. Next slide, please. So there we usually say that we usually do even the thyroid stimulating hormone to differentiate it between the thyroid disorder, mainly hypothyroidism, serum cortisol levels, if the female is having any feature of the Cushing syndrome, and serum prolactin level. Also, we see for the deficiencies with the complete blood count, the hemoglobin level, serum iron level, vitamin D and B12 level, and zinc level. More than 60% of the females who are suffering from PCOS are reported to have low levels, very low levels of vitamin D and even vitamin B12. So this becomes whole complete biochemical testing profile when you are taking the PCOS case into context. And also now previous slide. Also, we see the menstrual irregularities. The history should be like, they're getting less than 9 cycles per year, or they're having more than 35 days of gap between the cycles. That's what we need to consider. Or else they're having on ultrasonography, they're having more than 12 antral follicles in one ovary. Book says up to 20 also, and their ovarian volume is more than 10 centimeter cube. And you can see here when they do USG, you can see here there's a strong string of pearl sign, means it's making like a pearl. The follicles are in a way that they're appearing as a pearl, like a necklace, like appearance on the USG. So if a female is having any two of these present, we usually diagnose them as PCOS. Yeah. Yes, next please. So these are the few studies which we have published working with the PCOS women, where we have tried to evaluate more on their clinical, biochemical, and phenotype profiling, and also assessing their clinical, biochemical, and hormonal profile. And here I want to draw your attention, because when I was talking about PCOS, I have mentioned about overweight individuals. But when we did the study, we have found that there is a very fine difference between the chemical, biochemical, and hormonal profile of lean versus obese polycystic ovarian patient syndrome. So usually a thin female never think about that I can have PCOS. They think that only obese females usually have PCOS. But we have something called as obese PCOS and lean PCOS. Previous slide, please. I wanted to draw your attention here. You can see the one of the important findings from these study was that glucose abnormalities were noted 13.7%. There was glucose abnormalities even in the lean PCOS, and it was more in overweight PCOS. And even the insulin resistance, although they look thin, but mind me, there was an insulin resistance which was present in 50% of the lean PCOS females who were enrolled for the study, which is quite a huge number. Yes. So what is the basic difference between the obese and lean PCOS? Both having the irregular cycles, but in obese it is very significant as compared to the lean PCOS. The classical features, what we have discussed, they are present in the obese PCOS. But if you do biochemical testing, you will see the lean PCOS people will always complain of they're having anxiety. They are under some sort of stress always, or they are working in the night shift and their LH levels usually come high, whereas in obese category, it comes maybe elevated, not very high. And one of the feature which you can see in the lean PCOS is they will complain you of that after eating, I am eating frequently, but every hour I am feeling, you can say I'm feeling hunger. I'm feeling very hungry. It is because they're having something called as reactive hypoglycemia, and which is very classical feature of the lean PCOS. Now, what are the causes of these lean PCOS? Lean PCOS females usually have normal or even the low BMI. They look malnourished, but if you do their, muscle fat analysis, you will see the muscle is like a kuposhat child, and there is increased body fat percentage. Lean mass is very less. They look like a 40 kg or 45 kg, but inside that 45 kg is more of 60% is fat and hardly 20, not even 20% is not even 20, not less than 18% is muscles. So they look thin, but they are not thin. Then they have male pattern of the fat distribution. Male pattern of the fat distribution is male usually deposit the fat near the abdomen, where females deposit near the thighs. So these females usually have very thin structure, but only there will be a fat distribution near the abdomen, but not very evident. And as I've already mentioned you, they will have the abnormal fat to muscle ratio. They have high cortisol level, sedentary lifestyle, because lean people think that they are looking lean, so they're aesthetically good, so they need not to exercise, but and they can eat anything and everything because they are feeling hungry every now and then. That is again worsening the condition. They also have gut related issues. Vitamin D deficiency is found significantly, and definitely genetics play a huge role. Yes, next slide, please. Now, what are the treatment modalities available here is, we have the lifestyle management. Obviously, we have to think for the weight, we have to think for their physical activity, we also have to think for their sleep cycle. Here is lifestyle management. When we say, it has to include all the 6 pillars of the lifestyle, which I think Dr. Shalini have discussed in the last on the last Sunday about the 6 pillars of the lifestyle medicine. So we have to check about their weight, we have to check about their nutritional history, we have to check about their physical activity, we have to check about if there is any substance abuse, and if we have also need to check about their sleep cycle. Very, very important. Now, so many studies are coming which are showing a positive correlation between the PCOS and the sleep. So we have to check whether they are able to sleep well, whether they have the disturbed sleep and everything. Then in treatment modalities, we are giving them insulin sensitizers like metformin and oral contraceptive pills to regularize the hormones. Statin and hypertensives are used if there is increased blood glucose levels. And also the dyslipidemia, we are providing statins, and for antihypertensive if their blood pressures are high. And micronutrients, if we find deficiencies, 80% they will have vitamin D and vitamin B12 deficiencies. And then comes the role of adjuvant therapy. As Dr. Ranjan mentioned in the beginning of my presentation, that no one thing can treat the PCOS. That's very true. So it's like we have to take adjuvant therapies in hand to hand with the lifestyle management to cure the PCOS. Next is the paper which we have published on the seed cycling, the evaluation of effect of seed cycling on various parameters, including anthropometric, biochemical, hormonal, and nutritional parameters. In the women who were diagnosed with PCOS, it was a cohort interventional study design. And what we have observed, I'll just bring into your knowledge today. Next slide, please. This is in the Scopus Index journals. This study was taken with an objective to see if the seed cycling is going to change the parameters in the female who were diagnosed of the age group 80 to 40 years from the baseline, from the time they enrolled till the end of the 12 weeks. And we have 4 seeds over here. We used to give in a therapeutic dose. I will tell you the doses also. The pumpkin seeds and the flax seeds during the follicular phase, that is from the menstruation to the ovulation, and then sunflower seeds and sesame seeds during the luteal phase, that is from the ovulation till they menstruate again. Yeah. So what we have done is, what design we have done is, can you go to the next slide, please? Yeah. So what we have done here is, yeah, next slide, please. This could be omitted. Yeah. So we have assessed almost 314 females, and the females who have who have diagnosed and come under the Rotterdam's criteria, they have been included in the study. That is 290 we got, and we divided randomly uh, in them into the 2 groups. We have in control group 145 females, and in interventional group 145 females each. In control group, what we have done is we have given them the dietary modification on 1-to-1 basis, and they were put on the tablet of metformin 500 mg per day in consultation with the endocrinologist. And on the other group, we have given the same dietary modification, but instead of medication here, we tried with the seed cycling. Then what we have seen here is, we will see in the next slide. Yeah, next slide, please. What we can see here is we have studied all these parameters. So their demographics and everything was similar. And what we have observed, next slide, please. Next slide. What we have observed, I want to draw your attention here, the previous slide. If you see there, because we always say that they're overweight. What you can see there here in both the groups, their BMI was just 27, means they were overweight but not completely obese. But if you see their waist circumference, hip circumference, and waist hip ratio, it was high in both the groups. And with the seed cycling, there was decreasing waist circumference, hip circumference, and waist hip ratio. Okay, so that's very unique finding, you can say. Yeah, next slide, please. So similarly, we have seen on biochemical, I have marked in red so you can catch it easily. Their fasting blood glucose level, their triglyceride level, their total cholesterol level, and NDL level improved significantly. And also the HDL level, improved significantly from 43 to 51 in interventional group. And 43 also is a good number. You have to admit this also, So still they have improved with the seed cycling. Next, coming to their hormonal profile, you can see their FSH level, LH level, prolactin level, and testosterone level. They have improved. We can see the reduction in the testosterone level, reduction in the prolactin level. So this also was improved with the effect of the seed cycling. Now coming to their nutritional profile, if you see, next slide, please. Yeah, coming to their nutritional profile, we have given them only 1500 to 1600 calorie diet, but we have not given them a complete, nutritional plan as such, or diet plan. We have given them the guidelines. We have taken a plate in hand and we have shown them that how much grains they are supposed to consume, what should be the size of their vegetables, what should be size of their salads, what should be size of their lean muscle, like, all lentils and sprouts and everything. And we actually promoted here vegetarian diet, you can say plant-based diet over here. And we have monitored the compliance. We used to call them every 15 days to find whether they're doing or no. And also, these all seeds were provided from our research unit only, from our own setup. And we used to give them in the packets. They used to finish, come back, report, and then take the new packets. So that's how the compliance was also monitored, which was very tedious job, I must say. So the conclusion of this study was that we have seen that Women with the PCOS have shown the significant improvement with anthropometric biochemical and hormonal profile following 12 weeks of seed cycling. And seed cycling here means therapeutic dose, not 1 teaspoon or anything at any time. It was 2 tablespoons, that is your 15 grams. 2 teaspoons is your 15, approximately 15 grams. So 15 grams of each seed. So each seed we have given post lunch and post dinner. We have also taught them how they can use the seeds, with the in different forms, in chutneys, in with the curd, on the salads, and various things. And also there were few females who have dropped down from the studies because in between only they were positive for the pregnancy, and few females had the invariably traveling plan, so we have to take them out of the study. So but still we can see the results with this. So portion control diet, I will again say, portion control diet along with seed cycling, not only seed cycling, but portion control diet and seed cycling can be an effective strategy for managing PCOS symptoms. Now, next slide, please. Now, when we see the literature, we have the what are the possible mechanism, how these seeds actually benefited the women. So in the follicular phase, we have given them pumpkin and the flax seeds, which basically controls the estrogenic activity. Pumpkin seeds, they act as an potent vasodilator, antioxidants, anti-inflammatory, insulin sensitizer, and anti-hyperlipid. So these things I have collected from various research studies. We have various small research studies which are present on each seeds. So those have documented these. And also the flax seeds are rich source of estrogen agonist and antagonist properties. So both flax and pumpkin seeds, they're also rich in zinc and omega-3 fatty acid, which further help in synthesis of progesterone hormone for the luteal phase and regulate the follicular phase. And also these seeds helps to improve the blood flow to the uterine wall, so help in the follicular function. Whereas in luteal phase, consumption of sesame seeds and sunflower seeds helps in synthesis of progesterone. They contain lignin and zinc, which helps in inhibiting the excess synthesis of estrogen. Additionally, sunflower seeds are rich in vitamin E, selenium, further enhances the synthesis and action of the progesterone. So these are the possible mechanism how the seed cycling must be working in the females with the PCOS. Next slide, please. Now there are various supplements which are available over counter, and every supplement makes you or gives you tall promises that take iron, it will help you to improve PCOS. Take chromium picolinate, it will help you. So if I have to see each one individually, iron, yes. Chromium picolinate, it acts as an insulin sensitizer. Vitamin D and vitamin B12, folate, they help to regularize the hormones. Inostenols also is acting as an insulin sensitizer and insulin-like growth hormone. Omega-3 fatty acids is acting as mainly as an anti-inflammatory. And evening primrose oil also have shown promising results. But my take on this is only single supplement cannot help. It has to be a holistic approach by taking all the 6 pillars of the lifestyle medicine into consideration to treat PCOS patients. We have also many studies which are available on the herbs. Individual herbs have seen, like fenugreek seeds. They say that fenugreek seeds are acting as an insulin sensitizer. Same for the cinnamon, turmeric, antiseptic, basil leaves, ashwagandha, shatavari, muletti, and moringa. Moringa is drumstick leaves. So these herbs also have shown the results in small studies, but we need the larger studies to prove their more efficacy and exact efficacy and mechanism of actions. Next slide, please. My key messages here will be: aim for healthy weight loss, focus on a balanced, nutrient-dense diet, and support your body need. You have to choose local, seasonable, sustainable foods which are eco-friendly, which are available local, and don't complicate your food and your lifestyle. Stick to the whole and uncomplicated food. I always say that fad diet is a bad diet. So don't go for any fad diet, shortcomes, crash diet to decrease your weight. But here I want to address thing is weight loss is a concern with the obese PCOS, but where it in lean PCOS, it is not the concern. In lean PCOS, we have to focus on increasing lean muscle mass. So for them, weight managing strategies with the food, with the balanced food, will be the strength training. We don't recommend them in physical activity, more of cardiac activities, cardio endurance activities, but we recommend them more of strength activities to stimulate the muscle. Whereas in obese people, we give more of cardiac activity and 2 days of the strength activities. They need to skip the processed and packaged food, reduce use of plastics. Even when you are making salad, when we go for dinners and all, we see that salads and made and you are covering them with the thin plastic sheets to look them more appealing. But less plastic means healthier you and the healthier planet. Next slide, please. Yes, there are studies which has also shown the correlation of gut health in PCOS, mainly in the lean PCOS I have mentioned. So role of probiotics is huge here. So you have to take care of your gut also with a lot of fermented foods. Hydrate, hydrate, hydrate. Keep water close. Don't overhydrate, but hydrate as per needs of your body. Stay positive, take adequate rest, and cultivate the habit of having the gratitude and resilience. And again, as I mentioned you about the seed cycling, there's lot of hype of the superfood. I want to emphasize this last point that supplement and superfoods can support your health, but they are not the magic bullet or the magic pills. If you're going to give seed cycling without the 6 pillars of lifestyle medicine, their physical activity, nutrition, their sleep, and everything, these superfoods are not going to yield any results. So, usually, my patients ask me that we are very fond of green tea. We have heard green teas are doing miracles and we will lose the weight, our PCOS will reverse. And usually, I tell them your PCOS and your weight loss will be 100% if you're going to go to the Himalayas, pluck the leaves, get them, make tea yourself, and also invite me for the tea on the lighter note. Otherwise, green teas also will not help. So, no superfood will help if your other pillars are not aligned.